We are going to discuss the lesions which are seen in ovaries, and they include functional or benign cysts and tumors. The inflammation of the ovaries, which is uvaritis, are uncommon, and they are accompanied by tubal inflammation. Rarely a primary disorder involving the ovarian follicles, that is autoimmune uvaritis, occurs, and it is associated with infertility. Follicular cysts. The follicular cysts are very common in ovaries, and they are mostly seen in the reproductive age group. However, they can be seen at any age. They originate in the unruptured Greffian follicles, or the follicles which have ruptured and immediately sealed. These cysts are either single or multiple and are of variable sizes, maybe up to 2 centimeters in diameter, but they can be larger. They are filled with clear serous fluid and are lined by a gray glistening membrane. Granulosa lining cells may be identified if the intraluminal pressure is not too great. Luteal cysts. Luteal cysts are normally present in the ovary. These cysts are lined by a rim of bright yellow tissue containing luteinized granulosa cells. They occasionally rupture and cause peritoneal reaction. They contain blood, and sometimes old hemorrhages and fibrosis makes it difficult to differentiate them from endometriotic cysts. Polycystic ovarian disease was previously known as Stein-Leventhal syndrome. It's a very important condition, affects 3 to 6% of the females in their reproductive age. There are numerous follicular cysts which are associated with oligomenorrhea. Females suffering from polycystic ovarian disease, they have persistent and ovulatory cycles. They are obese. Hirsutism is seen in 50% of the cases. Rarely virilism is seen, and it's an important cause of infertility. Most of the females, they show increased LH-FSH ratio, and few cases there is increased level of prolactin. Grossly, both ovaries are rounded in shape, but they are 2 to 5 times than the normal size. Many small superficial cysts, they can be seen under the thick grayish-white outer cortex. On histological examination, the superficial cortex is thickened, it is hypocellular, it is collagenous, and one can see thick-walled blood vessels, multiple follicular cysts which are lined by an inner non-luteinized granulosa and an outer hyperplastic luteinized theca interna. Corpora lutea, they are usually absent. Wedge dissection of the ovaries restore the fertility. In many cases, a variety of enzymes involved in androgen biosynthesis, they are poorly regulated in polycystic ovarian disease. Recently, a link between type 2 diabetes and polycystic ovarian disease is established, and treatment of the type 2 diabetes results in the resumption of ovulation.